Here we have a 25-year-old woman, and this is a firm nodule on the cheek. Actually, probably it was a papule, but I think I wrote it down wrong and said nodule. But it's a firm bump on the cheek, okay? And thankfully, someone took a nice like large punch of this basically and punched the whole lesion out, which allows us to see not only the periphery but also the base. And we can see that this lesion is kind of a slightly polypoid, a sessile polyp, and there is a proliferation of little blue nests and cords and strands of tumor cells here in this very densely sclerotic dermis. Look how dense the collagen is, the pink collagen, compared to, say, the normal reticular dermal collagen down here, okay? And we can tell that this lesion is, even though it looks very busy and infiltrative in the middle, at the periphery, it's actually quite circumscribed. You can really see that there's a border to the lesion here. That's helpful. On a shave biopsy, unfortunately, which is what I normally see when I get one of these lesions, you won't get that clue. You won't be able to tell what it's doing down below, okay? There are two different things I want to point out to you. First of all, there's the presence of keratin-filled cysts, little microcysts that are filled with keratinaceous material. Sometimes these cysts rupture and produce keratin granulomas, which is what you see here, loose keratin and multinucleated giant cells. Very characteristic of this entity, but you can see that in a variety of different tumors, okay? Then the second component is these little cords and chains of very bland blue basaloid cells, all right? Some of them will have little enlargement at one end and then little tails. So people have likened these to the shape of tadpoles or sperm cells, if you like. And other people, maybe a little bit more old school, will say that these look like paisley ties, that old school kind of tie pattern that has the little tadpole shapes all, swirled together. If you're not sure, you can Google paisley tie to see some examples. So in DermPath, the paisley tie differential or tadpole differential includes four main things. Those are syringoma, basal cell carcinoma, infiltrative or morphiiform pattern of basal cell carcinoma, Desmoplastic Trichoepithelioma, and MAC, or microcystic adnexal carcinoma. Those four things can have this pattern of cords and chains that look kind of tadpole or paisley tie shape, okay? I think syringoma is the easiest one to rule out because usually right away, even on a small shave, you'll see multiple ducts. The ducts are very easy and obvious to see, and you usually don't have keratin-filled cysts. Basal cell is usually pretty easy because even though morphiiform basal can have areas like this, usually in a basal cell, you're going to find some areas that have peripheral palisading, clefting artifact, mucin around, or myxoid change in the stroma, or of islands of obvious basal cell. Not always, but I would say the majority of cases, you're going to see some other areas that look more obviously like basal cell. But the problem, I think, is to determine between desmoplastic trichoepithelioma, which is what this case is here, and microcystic adnexal carcinoma. Those two can look essentially identical on H&E, and really the most important thing is seeing the base of the lesion. Microcystic adnexal carcinoma usually infiltrates deeply into the subcutis and even the skeletal muscle. I've seen rare exceptions that extended out laterally but didn't go down very deep, but usually they go deep. They are very rare, but they are locally aggressive and often require more extensive surgery and have a significant chance for recurrence. Desmoplastic trichoepithelioma, on the other hand, is a benign entity that is cured easily with simple excision. The thing, if I have a shave and I'm not sure, I may say I favor desmoplastic trichoep, but I can't see the base, and I usually recommend them to do a small excision so that I can see the base, or at least give me a punch so I can see the base of the lesion. These are relatively uncommon. I only encounter them a few per year maybe, so it's not like I'm telling people to go and do re-excisions that are not necessary left and right. I only encounter this occasionally, okay? As you might have thought, though, this is a type of hair follicle tumor, whereas MAC is a type of sweat gland tumor. So MAC should have sweat duct differentiation. You should see obvious ducts. And desmoplastic trichoep should not. Well, that sounds like it should be easy, but it's actually in practice, I think, quite hard because I feel like MAC, oftentimes on the superficial aspect, you get these keratin microcysts and you get very compressed little strands. And if there's a duct, it's very difficult to see the lumen of the duct. Uh-oh, what's this? That looks like a duct. Well, remember that normal skin also has sweat ducts in it. And so it's really hard also to tell if you see an occasional duct like here or here, is that part of the tumor or is that a background sweat duct? So it can be really challenging to determine if something has ducts. In MAC, when you have a deep enough biopsy or an excision, oftentimes you'll begin to see obvious duct differentiation down deep. And MAC, even though it is a cancer, it does not usually have much cytologic atypia. It's very bland, and cytologically, to me, looks essentially identical to either normal sweat ducts or to the cells that you see here in a desmoplastic trichoepithelioma. You can do various immunostains, and a lot of them have been tried over the years. The one I find most helpful is cytokeratin 20, which highlights scattered cells in desmoplastic trichoep and many other benign hair follicle processes. But usually you lack those cells in basal cell carcinoma, and you usually lack those scattered 20 positive cells in MAC, okay? Now, those 20 positive cells, what they are, they're actually Merkel cells, not Merkel cell carcinoma, but normal Merkel cells that are kind of hanging out as what I like to call passengers. They're kind of colonizing. So you can have these. This is not from this case. This is, in fact, is from a different benign hair follicle tumor. This was a trichofolliculoma, which is we're not going to cover today. But trichofolliculoma showed this, and this was done for teaching purposes. A very nice example of these scattered cells that are just kind of hanging out in the middle of the lesion. And if you do a CK20 on normal skin, you'll often see them too, kind of hanging out in the basal layer of the epidermis as well as in the hair follicles. I find that they often highlight the openings of hair follicles, and likewise you see them scattered in the midst of trichoepitheliomas, trichoblastomas, trichofolliculomas, and desmoplastic trichoepitheliomas. So it can be a really useful tool if you find a colonizing with these passenger benign Merkel cells on CK20 stain that's supportive of a benign hair follicle tumor. It's not a perfect stain, but of all the stains described and the ones that I've used in my practice, I've found this one often helpful. But more important than all of that is I want to see a biopsy that's deeper than the shave. I want to see the base of the lesion, okay? I'm going to point out one last thing before moving on to the next case. And this is something that I've changed in my views on since I started practice. I was taught, as many people were, that if you see perineural invasion or involvement by a tumor, that supports MAC, not desmoplastic trichoep. But then the Yale DermPath group, some members from the Yale DermPath group described that you can have desmoplastic trichoeps with perineural involvement, and that's what we're seeing here. You'll have to believe me, I can't go any closer, but that is actually a tiny little nerve, and it's wrapped around by those benign-looking, bland, blue basaloid cells. So they presented in that paper, and it's by Dr. Yedrick and Dr. McNiff and colleagues, and they did a very beautiful job of highlighting several cases, multiple cases, I think they had 6 or 7 if I recall, that were desmoplastic trichoep and had perineural, they don't call it invasion, but involvement by tumor cells, and yet had no recurrence and no bad outcomes. And I felt that they handled it so beautifully in the discussion that it really, reading that paper, changed my view and my practice on these. And in fact, in this case here, this spared this young woman from having a decent sized chunk cut out of her face, which is what would have happened if I would have called this microcystic adnexal carcinoma. And this was several years ago, at least, and to my knowledge, nothing bad has happened to this patient. So I'd like to point that out because that's something that paper, you can go and check it out. If you Google perineural and desmoplastic trichoepithelioma, it should pop up right away. And it's a really great paper, actually, about why things grow around nerves in general. So I actually thought it was just a beautifully done paper, and really bravo to those authors for writing something so nice and elegant, and something that was so practical as well. All right, so a nice example of desmoplastic trichoepithelioma. And if I don't have another example of regular trichoepithelioma in here, but if you've ever seen one of those, it looks totally different from desmoplastic trichoep. And in fact, I think that they are probably 2 different tumors that they are both hair follicle tumors, but otherwise not really related, because in my experience, all of them, they don't usually have areas that look like regular trichoep. They just look like their own thing. So that's my thought, but I'm sure that there are other people more educated than me that have different views, because there's nothing that dermpaths love to argue about more than adnexal tumors. So it's funny because it's true. All right.